All right. Wonderful. Hello, and welcome to the third webinar in the series presented by Midwifery Access California. I am Olivia Favela-Gary, and I am a nurse midwife and the executive director of the California Nurse Midwives Foundation. More about the foundation in a moment. But first, thank you for being here today. Today's webinar is for anyone interested in learning how the regulations and laws for midwifery practice in California could better serve birthing people in the state. Specifically, we hope that legislative staff in California, advocacy organizations, and legislators find this helpful as you plan your legislative and advocacy agendas in the coming year. Slide, please. This webinar was created in partnership with the California Nurse Midwives Association, the California Association of Licensed Midwives, and Global Communities Healthy Start San Diego Riverside. The California Nurse Midwives Association is a professional association for nurse midwives in California, and similarly, the California Association of Licensed Midwives is a professional association for licensed midwives in California. Today, you will learn about these two different midwifery licensure types here in California. These two organizations are your key resources for matters affecting the midwifery profession. We are thrilled that Global Communities Healthy Start San Diego Riverside has joined us in marketing this webinar. This organization provides free prenatal and childbirth education, postpartum, and breastfeeding support with a focus on Black, Native, Hawaiian Pacific Islander, and Native American Alaskan Native parents throughout San Diego and Riverside counties. Enrolled participants may access free midwifery and doula services, as well as other resources that ensure a positive birth experience. Services are available in English, Spanish, Somali, Haitian Creole, and French. Next slide, please. And finally, as I said previously, I am the executive director for the California Nurse Midwives Foundation, and we are proud to support this webinar series. Please scan the QR code on this slide to learn more about our work and funded projects. The foundation's mission is to enhance maternal health in California and address disparities in birth outcomes by advocating for universal access to the midwifery model of care, driven by a diverse midwifery workforce. Our work encompasses reproductive care, abortion care, and more, reflecting our commitment to holistic healthcare. CNMF has funded various initiatives that fall into three categories that you can see here on the slide. Today's webinar is part of our Midwife Aid and Midwife Advocacy arm, or what we aptly call MAMA. Our Bloom arm funds and provides support for vital community projects in order to ensure that local midwifery is available to those who need it most. And finally, our Seed arm directly funds midwifery student scholarships, particularly for BIPOC and LGBTQ plus students, as part of our commitment to diversify the midwifery workforce. I just want to reiterate that as part of our advocacy and midwife aid work, the foundation is also directly available to you in your roles as staffers and advocates to provide technical assistance or guidance in your endeavors to advance the midwifery profession and improve access to care. Our email is also there on the slide. Don't hesitate to reach out. Thank you again for being here today. And with that, I will pass it to Holly Smith.
Thank you so much, Olivia, and thank you everyone for being here. I'm going to introduce myself and our other panelist, Madeline Wiesner. Madeline Wiesner is a California licensed midwife and a New Zealand registered midwife. Madeline served as clinical director to a busy community birth practice in Sacramento as one of the few licensed midwives providing midwifery care to families with Medi-Cal. She is especially passionate about increasing access to respectful, affordable, and clinically excellent midwifery care for poor and working class families in California. She serves as the vice president of California Association of Licensed Midwives and is also the chair of the Midwifery Advisory Council of the Medical Board of California. And I am Holly Smith. I am a nurse midwife. I've been a nurse midwife for about 24 years. I have worked primarily in hospital practices across the world. I am also one of the co-facilitators of Midwifery Access California. Madeline is also a key member of Midwifery Access California. I am the legislative coordinator for the California Nurse Midwives Association, and I wear various other quality improvement and policy and advocacy hats in California surrounding midwifery integration. So for some of you, if you do not know already, Midwifery Access California is a multi-stakeholder coalition. It started in 2021. We have now more than 60 plus total partners, more than 25 midwifery practices, which include both CNMs and licensed midwives. This includes midwives who attend births in the home setting, in the hospital setting, in freestanding birth centers. We also have local and state agencies who are part of the stakeholder coalition, including LADPH Perinatal Equity Initiative, the California Department of Health Services, and many community-based organizations and professional orgs. Some of their logos are here in the top right. And we have 3 Medi-Cal health plans now involved in Midwifery Access California. And if you all hold on for 1 second, I'm going to change my view so I can see my notes. Liz, can you give me a heads up? Are you seeing just my notes or
just the
I'm sorry.
slide still?
Slides
We're
great.
not seeing your notes.
It switched back for some reason. So thanks everybody for your patience. So MACA is what we are calling Midwifery Access California. MACA was born from the Midwifery Learning Collaborative, which was a 3-year project of the Institute for Medicaid Innovation. And the members of this group envisioned a continued collaboration of diverse healthcare and community-based experts to carry on the work of midwifery integration in California. And so Midwifery Access California was born. While our coalition comprises diverse stakeholders, we agree that access to midwifery is a crucial strategy for improving reproductive health care, access, and outcomes in California. We aim to integrate the midwifery model of care into existing care settings, including amplifying and expanding community midwifery. This coalition's initial focus has been expanding access to midwives for Medi-Cal beneficiaries. All right. So today we are going to learn about the history of midwifery in the United States and California, why midwifery is a strategy for this double crises of poor maternity care access and racism-based disparities in birth outcomes. Also, the importance of midwifery integration and how it can be achieved via legislative and regulatory changes in California, and why the patient safety argument against independent autonomous midwifery practice is a myth. And then we'll also go over some legislative possibilities on regulatory possibilities and next steps to better integrate midwives in California and thus better access and outcomes for birthing people. So I do hope you stick around till the end. Hopefully we'll also have a chance for a few questions and answers should we get through these slides in time for that. You all will be receiving these slides, by the way, tomorrow, as well as the recording of this so that you can refer to it in the future as well. So let's first talk about the problem. Also, this is a series, this is a webinar series, so I encourage you to go back and see webinars 1 and 2 if for some reason something doesn't make sense to you, or if you want to learn more, please go back to those. But in a nutshell, there's a maternity care problem in the United States, which includes poorer maternity outcomes than other high-income countries, racism-based disparities that persist despite efforts to improve outcomes, and lack of access to reproductive health and maternity care. Previously, I said it was a double crisis in California, and of course you see here that there are 3 problems we're talking about. The reason we say double in California is because actually California is doing a little bit better than most states in terms of maternal mortality, generally speaking. In fact, if you look at maternal mortality in California, generally speaking, we're doing a lot better than other states. A few years back, we looked, in fact, kind of closer to what you would see in Scandinavian countries who tend to have the best maternal mortality rates. You don't see that, though, when you parse the data by race and ethnicity. That's when you see that Black birthing people in California and other people of color have much different birth outcomes than their white counterparts. And so here's just a chart showing that. The red line shows the United States, the blue line shows California. This is more recent data. You can see that there has been a steady increase since 2012, probably somewhat related to how we now better count maternal mortality and perinatal related mortality. But we're still much lower than the United States. And in fact, it is likely that maternal mortality ratio is undercounted in the United States than what it shows here, because California has an enhanced surveillance system that is more advanced than other states. So I just want to point that out. So now you can see what the data shows country by country. The US there is way over on the right side in the green tabs. Um, California, per the last slide, probably sits somewhere in there between New Zealand and that first green bar. But overall, the country not doing well comparatively to other high-income countries. And you can see for Black birthing people in the United States, the disparity is stark. This shows that same thing, racism-based disparities in California. The blue line being Black birthing people, and the other colored lines below that being other people of other ethnicities, white birthing people in California having the lowest rate. And then finally, the third problem we were talking about is poor access. And access to maternity care in California is worsening. These graphics show a report by Cal Matters and Kristen Wong in November of 2023. Kristen Wong has continued to report on this for many months now. They published their investigation on maternity ward closures in California, and at that time, they showed that at least 46 California hospitals have been shut down or indefinitely suspended their labor and delivery services since 2012. That number now is more like 51 or 52. So even since this has been published, the number of facilities closing their maternity wards, maternity units has gone up. In fact, it's as if we can't turn around without seeing another report on the loss of services. And all of these are recent newspaper, I was going to say newspaper clippings, but who does newspaper clippings anymore? Screenshots. These are recent screenshots of reports on these closures. And it's hard to conceptualize this unless we have a visual. So I'm going to just keep clicking here until this page fills out so you can get a sense of just how dire this situation is in California in terms of perinatal units closing. Over 50, as I said, have closed since 2012. 29 of those have been between 2021 and 2024. So here's what I hope you're getting from this. The take-home point here is that we need to retain maternity services, obviously, but also midwives and freestanding birth centers, home birth, have continually stepped to fill the breach in recent times and will continue to do so. But if we restrict access to midwives, we make this problem worse. And those three ones that popped up there that are bigger are the ones that most recently closed just in the last few months. And if you go to this QR code later, you'll see the Cal Matters No Deliveries series, where they have compiled all of their investigations and stories on this issue of poor access in California. You'll also see that there's a few stories there about birth centers in California. Our last webinar in this series was about freestanding birth center closure, which we are desperately trying to stop. And this webinar is an integral piece of that because regulation and legislation are probably the foundational building blocks of why freestanding birth centers in California have difficulty surviving. So here's what all of this means. This is the reality check. California now has 56 rural hospitals, 10 of which are at risk of immediate closure. Only 24 of these 56 rural hospitals have maternity units. There's also approximately 37 critical access hospitals in California. And critical access hospital, many of you are familiar with, this is a CMS designation for facilities that are pretty far from other facilities and thus are critical access to their communities. But of these critical access hospitals, fewer than 10 have a maternity unit. And hot off the press, this was an article that came out yesterday in the New York Times. It highlighted what's going on in rural Plumas County here in California that has lost maternity services and how they hope that midwives and a midwife-led freestanding birth center can be a critical source of care. And by the way, it's important to note that these problems of poor access and outcomes are not mutually exclusive. They are linked, as all complicated problems are. As an example, this research published in the Journal of the American Medical Association shows the association between the loss of obstetric services in rural areas and increase in preterm birth and increase in unintended out-of-hospital birth, which of course makes sense. So access, outcomes, and disparities cannot be separated from each other. So now let's jump into the reason we're here. Why is midwifery a strategy to improve outcomes and access? Well, to understand that, you need to know what a midwife is. So for the newbies here, the others can just tune out for a second, but to lay the foundation for folks who are not familiar with midwives or the midwifery model of care, I'll talk a bit about that. Midwives are healthcare providers who care for pregnant people and newborns during pregnancy, labor, birth, and the postpartum period. We provide preventative care and detect abnormal conditions. We consult with physicians and refer patients to physicians and other healthcare providers when indicated. We even provide emergency care until the need has resolved or additional assistance can be obtained. We can manage a number of complications also independently within our midwifery scope of practice in terms of what we've been trained and educated to do. We prescribe and or administer medication. We can order and interpret labs and imaging. In some cases, we perform or order ultrasounds within the midwifery scope of practice. We suture lacerations after childbirth. Also, nurse midwives in California, and you're going to learn about nurse midwives and licensed midwives during this session, but nurse midwives in California can provide routine gynecologic care, meaning like pap smears, typical vaginal conditions that need treatment, sexual transmitted infections, and nurse midwives in California can independently perform abortion in the first trimester, both medication abortion and aspiration abortion. So also for the new folks here, let's review the data. The research and the data at this point is innumerable. The evidence shows that the midwifery model of care for essentially healthy people results in excellent outcomes for women and birthing people and decreases, and for neonates, and decreases the outcomes we don't want, like preterm birth and cesarean birth, NICU admissions, excuse me, neonatal death. Those things are decreased when in an integrated system of midwifery care. One second, I'm sorry. And these great outcomes that result from midwifery really stem from the philosophy and model of care, which is relationship-based and patient-centered. So, as I said, this is a webinar series. I encourage you to go back and look at these three sources via these QR codes to find out more about the philosophy and model of care. But put succinctly, midwifery care is whole person care. The midwifery philosophy views pregnancy, childbirth, and the postpartum period as integral pieces of the life course rather than separate transactional healthcare events. In the community midwifery model of care, patient-centered care, comprehensive care management, and linkages to social services, all of that is baked into the model of care. So in a nutshell, if you were to put your finger on the three things that produce such great maternity outcomes, it's the fact that midwifery preserves these three elements: partnership with the birthing person, meaning patient-centeredness, a relationship-based model, the therapeutic use of the human presence, and non-intervention unless necessary for the health and well-being of the pregnant person or the fetus. So I know what you're saying. You're going to say, prove it, right? Because many of you have perhaps heard something different. There are so many studies on midwifery outcomes now that it isn't possible to talk about all of them. And frankly, we no longer need to convince rational people of the data, but it's there and it's abundant. But I know you're all itching to see something that proves the safety of the midwifery model. So I'm going to show you a few studies that are key and very recent. And this is really important because it will help you understand later when I talk about the patient safety argument against autonomous midwifery care as a myth. So the first one noted here, this seminal study by the folks over at the Birthplace Lab, happened in 2018, and it looked at the integration of midwives across all 50 states, and it gave a score to each state on their level of midwifery integration. And then it also looked at maternity outcomes in that state. And in terms of how they defined integrated midwifery, which isn't really a defined thing just yet, it's kind of one of those things, you know it when you see it, and you know it because how other countries have integrated midwifery into their healthcare systems. But the Cliffs Notes version of this is they defined integration in these states as scope of practice that's consistent with the midwives' training and education rather than restricted scope of practice, which happens in many states and still is somewhat like that in California. They looked at autonomy of practice, meaning no physician supervision and truly being able to practice the midwifery model of care. They looked to see if midwives were regulated by midwives, which is one of the International Confederation of Midwives standards. And they looked to see if there was collaboration across disciplines and the ability to collaborate across disciplines, because that's a really important thing to be able to do that when you're a midwife, to be able to consult and transfer patients to a higher level of care when needed. And they looked at the density of midwives in those states and access. And the result was that states with higher midwifery integration scores had better birth outcomes. And here are just a few: increased breastfeeding, reduced interventions, increased vaginal delivery after a cesarean. That's important because more and more we're finding that cesarean section rates are a key indicator or reflection of maternal health in a region or in a state. And they also saw lower neonatal death in those more integrated states. So I bet you're saying, hold up for a second, because folks who are staffers and advocates oftentimes get a lot of information from a lot of different stakeholders, and this might seem off to you. We've just noted that being able to practice within one scope that matches their midwifery training is an important part of midwifery integration. And we've just shown that midwives are extremely safe providers and produce stellar outcomes. So why is it then that the American Medical Association, and in some cases in California, the California Medical Association and ACOG, sorry folks if you're on the call, we're just trying to have the most honest and real conversation here, but why do they continually fight against independent practice and fight scope of practice bills for midwives? Seems kind of weird, right? Given what I've just discussed. So maybe you're thinking, aha, I know the issue. It's not that they have a problem with midwifery in general. It's that they have a problem with like home birth and birth outside of the hospital setting. And they're really worried about that for patient safety because that's not safe, right? Home birth and birth outside of the hospital isn't safe, if that's what you're thinking. Well, hold that thought for a second and let's talk about home birth. ACOG has published a home birth statement that has not been revised since about 2017. Since that time, there has been so much more data on home birth in the United States in really well done studies that it's time they should probably revamp what their practice statement says. But here's one study that came out in the, I believe is the Green Journal, which is the journal of the American College of Obstetrics and Gynecology in 2021. And it showed that birth in freestanding, well, first I should say, ACOG says in their statement that birth in an accredited freestanding birth center is safer than home birth. And so they suggest that birth take place in an accredited freestanding birth center or in the hospital setting. But what this study found is that home birth outcomes matched freestanding birth center outcomes for patients appropriate for midwifery care in an integrated system. These were patients in Washington State, and Washington just happens to be the most integrated state per that study that showed the integration scores. And these outcomes, by the way, perinatal mortality is what they were looking at, actually match the benchmark rates that ACOG uses for hospital birth. And since that time, just this last week, I believe, these same authors went back, looked at more home birth data, and solidified that this is in fact the case. And one of their recommendations was that ACOG should revise its home birth statement. And if you're still not convinced, let's talk about the CMS Strong Start study. This study was very large. It's a federal study over about 5 years, I think back in 2018. It included majority Black Medicaid recipients. And what they did is they compared three really great models of care. They compared comprehensive care management, or what in the study they call a maternity care home, which is not a home people live in, but rather having like a patient navigator and comprehensive care management, compared against group prenatal care, often by midwives, compared against the full midwifery model of care in a freestanding birth center. And what they found was birth center participants have better outcomes relative to comprehensive care management participants after controlling for their demographic, medical, and social risks. In fact, what they showed is they had lower rates of preterm birth, lower rates of low birth weight babies, lower rates of C-section, higher rates of vaginal birth after cesarean, which is a good thing, all at lower costs. Also, fewer infant emergency department visits and hospitalizations and more. But you don't have to take our word for it. Midwives as a strategy is well known, and even the White House blueprint says midwives are a critical piece of the maternal care workforce. Okay, so back to that American Medical Association slide. I think we can safely say then that the patient safety argument against independent midwifery practice is a myth. But I really want to put a fine point on this. So here's a little anecdote that I hope further makes this point. I have in red here that the AMA successfully what does it say here? Successfully fights scope of practice expansions that threaten patient safety. So this is from their website in 2023. And they show that 11 scope of practice bills were defeated in Mississippi. Now, 11 scope of practice bills, that's crazy. I mean, a couple scope of practice bills, as you all know, at the same time in California at any given time is a lot. But Mississippi had 11 in 2023, which says that lawmakers, well, it says to me anyways, that lawmakers and constituents really, really want something other than what they're getting in the healthcare space and the maternity care space. One of these bills, as it turned out, was a bill to introduce the legal practice of professional midwifery in Mississippi, and it failed. And the AMA seemingly was thrilled about that in terms of what is on their website. And this is even though the Mississippi Delta has the highest rates of maternal mortality. In fact, in 2021, Mississippi had the highest rate of maternal death. We also know that states with the highest maternal mortality rate also have some of the highest shares of Black births. That is the case for this data here in Mississippi, highest maternal mortality rate, highest share of Black births, meaning a greater proportion of Black birthing people are dying in that state. We also know they have significant abortion restrictions there, and states with abortion restrictions have the fewest number of maternity care providers. So Mississippi down there at the bottom is in the darkest brown color. They are one of the states with the fewest maternity care providers. Also, they're dark blue in this map that shows low-risk cesarean births. And as I said previously, cesarean is a key indicator of lower quality maternal health care. And so they have some of the highest rates of cesarean. And finally, in terms of those midwifery integration scores that we talked about previously, Mississippi ranked number 46, so almost the worst in terms of midwifery integration. And all of this comes around to say that the Commonwealth Fund named them as the worst state on health and reproductive care outcomes, which one might say is the worst in terms of patient safety, right? And yet, the AMA wanted to successfully fight scope of practice bills, especially for licensed midwives in Mississippi that could possibly make a real difference in access and outcomes. So I just want to put forward to you that patient safety arguments against independent midwifery practice aren't just a myth. They actively bring harm to birthing people, which is what is occurring right now in Mississippi. And By the way, if you're wondering, the California Legislative Analyst Office and the Federal Trade Commission both agree that physician supervision requirements and restrictions on scope of practice impede access and raise costs. The Federal Trade Commission is saying even well-intentioned laws and regulations may impose unnecessary, unintended, and overbroad restrictions on competition, thereby depriving healthcare consumers of the benefits of vigorous competition. And another reason we know that this argument is a myth is from what we know about midwifery around the world. So let's take a look at that. So the midwifery model of care is standard in all countries that have better birth outcomes. So you can see in orange here, that represents midwives. Blue represents the number of physicians, or excuse me, obstetricians. This is not to say that we shouldn't have obstetricians or that having more of them than midwives is a bad thing. Rather, we at CNMA and CALM fully believe that a system is better when we're working together. And actually, midwifery does not work unless you have physician consultants, especially for people who need a higher level of care, who have chronic conditions, who develop something during the course of their pregnancy, and so forth. But what we're saying is other countries have determined that the midwifery model of care saves money and improves outcomes, and their data shows that. South Africa is an interesting one that Madeline sent over to me, and you'll hear from her in a little bit. But South Africa actually has a national guideline for respectful maternity care. And that's important because they've created standards specifically and explicitly to prevent apartheid in maternity care and healthcare in general. And what they say is that midwife-led models of care are recommended for everybody for whole person, respectful maternity care for all. But midwifery care in other countries isn't just about improving respectful care and therefore reducing obstetric violence and reducing racism-based disparities. But other countries also utilize midwives as a key strategy to improve outcomes for the most vulnerable. And a lot of times people think, well, yeah, if you're in a developing country and your maternal mortality rates are already pretty bad, any kind of care is going to improve outcomes, right? But what I want to show you here is that most of the countries noted here in orange highlight are high income countries. Australia utilizes midwives to impact rural and remote and indigenous mothers, young mothers, socially disadvantaged. Canada, same thing, rural and remote, indigenous. Denmark's interesting. They integrate midwives in order to work with chronic conditions. And in our country, we often say, well, that would definitely be out of the midwife scope. But midwives as a first primary provider, a gatekeeper provider who can then refer clients to the appropriate level of care makes a difference. So if outcomes are better when midwives are integrated into the healthcare system and the rest of the world knows this and does this, why are we so behind? Well, there's actually a long history of care by midwives in the United States. In fact, in the 1800s and the 1900s, most midwives at this time were immigrants from Europe or grand midwives, meaning Black midwives who were the descendants of enslaved people. And then, of course, indigenous midwives and Native American midwives, and they were attending the births of people in their own communities. And here are just some photos of a great photo spread in Life magazine from, I think, like 1956, showing Black midwives in the South. So around 1910, the Flexner Report was published, and it showed that the American healthcare system was doing really poorly in terms of obstetrics. And so what the medical community needed was both funding and attention diverted to medicine in order to improve what physicians were doing in both their training and outcomes in the hospital setting. Additionally, this was Jim Crow era. Black midwives, being majority of midwives in the South, were, of course, attacked by racist and xenophobic stereotypes. They were called evil and inveterate quacks. And Black midwives were particularly called out for being dirty and uneducated and so forth. So you see where this is going. Oops, actually, I'm going to go back real quick. In 1920s, however, nurse midwifery kind of sprung up in the United States, but unfortunately, nurse midwifery, starting at the Frontier Nursing Service, also specifically forbade Black students from training. So this is an interesting slide as well. You're like, why are we putting up an abortion slide here when this is not the talk that we're having today? But what I wanted to show from these articles is that abortion's first major foe in the US were physicians on a mission to regulate medicine. And actually, I need to zoom in on my own slide here to read this for you. But the American Medical Association started the anti-abortion movement in 1857 to wrest control of reproductive health from the purview of midwives. Criminalization of abortion at every stage, except for those deemed medically necessary by a physician, restricted clientele from midwives and homeopaths who previously dominated the maternal health and women's health care. So just this to show the following, that the history of midwifery in the United States is a history of systematically regulating midwives out of existence, often speciously in the name of safety, and explicitly eradicating community midwives who were predominantly Black, Indigenous, or immigrant. And this continues to this day. The dominant model of care still believes midwifery is lesser than, and this has kind of spread culturally. You might even have thought this or think this at the current time. Many folks believe that midwives have subpar training. Health plans call midwives mid-level providers and often reimburse less than physicians for our really intensive, personalized, patient-centered care. And there continues to be stigma around home birth and birth outside of the hospital setting that's not really grounded in the evidence, as I recently noted with the home birth studies and how we need to revamp that home birth statement, the National Home Birth Statement. There's also a refusal to integrate and see how we are better together. And in our opinion, we could be doing so much more, so much better together. For example, in California, the Sutter Health System is a great example. Patients sign a form that say if they plan to have a birth at home, they are mandated to find another care provider for their prenatal care, meaning that they can't even get prenatal care if they are going to have their birth in the home setting. And that's dangerous and frankly goes against every midwife bone in my body that says patients have a fundamental human right to access healthcare, regardless of what the medical providers or the system personally believes. All right, so this has resulted in a patchwork of midwives in the United States, and this is confusing, right? And I imagine this will be clear as mud by the time we're done here. But if you have questions about it, always feel free to reach out. So we have in the United States CNMs, certified nurse midwives, certified midwives or CMs, and certified professional midwives or CPMs. CNMs are trained as nurses and midwives. CMs take the same national board as CNMs, but do not have a nursing background. And CPMs are also called direct entry midwives like CMs, meaning simply they are a non-nurse, but who train in a community setting for the specialty of doing community birth. I'm not going to say more than that because Madeline will discuss this in the California slide, but suffice to say that midwifery in the US has morphed and grown out of this initial attempt to make us obsolete. And from that near-death experience grew this almost Frankenstein mishmash of credential types and differences in state laws and scope of practice. And here's what practice environments look like for each of these. This shows nurse midwives in the United States. CNMs are legally allowed to practice in all 50 states, but each have differing restrictions. The states in green have what we call full practice authority, meaning full independent practice for nurse midwives. And that's actually the majority of US states. So nurse midwives have made some progress. You can see California is not exactly dark green, it's light green, but we are in fact making progress. And we'll talk more about that coming up. Certified midwives have legal authority to practice only in 12 states, also with different restrictions. Certified midwives cannot legally practice in 38 states and can even be penalized or even face criminal charges if they do practice. And then certified professional midwives have legal authority in 38 states and District of Columbia. So that means 12 states and 3 territories. They are at risk of criminal prosecution for practicing, and that's those gold regions there. This drives the practice of midwifery underground and creates barriers to access for women seeking maternity care. All right. So, to understand midwifery in California, um, it's important to understand how this unfolded. And with that, I'm going to pass this to Madeline, and she will tell me when to go to the next slide. Take it, Maddie.
Hey, everybody. I just wanted to thank everyone for being here and thank Holly for such a thorough presentation on all of this and for handling my slides for me. So midwifery has somewhat of a unique history as one of 50 United States. Many people do remain unaware that midwives of Indigenous, European, African, and Asian descent served as primary birth attendants from the earliest days of colonization, as well as predating colonization. And as long as California has existed, certainly midwives have existed. As increasing numbers of people in California and nationwide are seeking out midwifery care today, it's really important that the general public and policymakers understand the broader history and context of midwives in California. I'm going to be presenting a little bit of information that is derived from a white paper that is forthcoming from California Association of Licensed Midwives. This white paper was put together by Catherine Hempel, who looked at really a lot of historical data. Much of it was from Faith Gibson, who conducted pretty groundbreaking research using original source materials, specifically in regard to Californian midwifery. So with that, we can go to the next slide and look at this. So as Holly had said before, that there were three main types of midwives in the US. First of all, I would say that there is another category of the traditional midwife. We try at CALM to use words that describe midwives and births rather than describing them as what they are not. So traditional midwives, also known as midwives who are not licensed, make up a very large proportion of midwives in the United States, particularly in states that don't allow licensure at all. They still have midwives, and they still have midwives that need to be recognized as experts in their fields. California, we have two main credentials of midwives. We have licensed midwives, who specialize in birth that takes place in the community setting and care that takes place in the community setting. This has been referred to as out-of-hospital birth, but as I said, we want to define things by what they are, not what they aren't. So community midwives tend to be licensed. They go through a specific set of training that actually exceeds the CPM training. But most licensed midwives complete the CPM certification exam. Certified nurse midwives are the other credential of midwife in California. Most of those midwives are working outside of community. They are out of community providers in hospital settings and in FQHCs. We can go to the next slide, I think. So licensed midwives are licensed by the Medical Board of California. Many do carry the CPM certification, as in most cases it's required to pass the CPM exam to gain licensure as a California midwife. But many of us, self-included, no longer carry the CPM credential and only carry the licensed midwife credential. The certification body for CPMs is NARM. The Professional Association for Licensed Midwives in California is CALM, of which I am a board member. And most licensed midwives do provide care in homes, freestanding birth centers, and outpatient clinic settings. Whereas nurse midwives are licensed by the Board of Registered Nursing. Their certification body is a national certification body, AMCB. Their professional association is CNMA, as we all hopefully know, and the majority of CNMs provide hospital and outpatient clinic care. However, they also can provide care in home and community settings. Next slide, please. So I want to point out that the practice locations for California midwives on this slide, that is sorted by volume, not by like one being above the other. So most midwife attended births in California take place in a hospital with certified nurse midwives, and most certified nurse midwives practice in hospitals. Whereas both LMs and CNMs provide care in community settings, and LMs far exceed the number of CNMs providing home birth services. There's some information about the training pathways. One thing I really want to drive home is that licensed midwives are required to go to midwifery school and to complete clinical practicum in a community setting. So they are specifically trained to attend prenatal care, births, postnatal care, interconception care, and well person care in a community setting. Next slide, please. So CMQCC in the vaginal birth toolkit is a really important piece of learning material for all stakeholders in maternity care in California. This thing is the bomb. And it was recently updated to include a bit more about team-based care as well. And this provides a pretty awesome just overview of the types of midwives in California, as well as local and global standards for midwifery care. Next slide, please. So midwives in California, by the numbers, approximately 1,600 midwives total, according to a 2024 California Healthcare Foundation report. There are approximately 900 midwives who are Medi-Cal providers, the vast majority of which are nurse midwives working in larger health systems that are often like federally and state required to take Medi-Cal. Looks like as of the end of 2019, there were 43 licensed midwives taking Medi-Cal, and I can say that that number has been drastically reduced in the midst of ongoing frustration with reimbursement, as well as the pandemic that is ongoing. There are fewer than 40 total freestanding birth centers in 2023. Now there are way fewer. They are closing at such a rapid pace that we can no longer keep track. 19 birth centers have closed since 2021. There are only 4 licensed birth centers left in California, which is a cry and shame. Overall, midwives in these 2 credentials attend 11 to 12% of births in California. Next slide, please. There are currently no licensed midwife education programs in California, although one is in the works. And there are only 2 CNM education programs in California. So as far as training for midwives, to support this workforce for which there is an incredible demand and an incredible need, we don't have a lot of training options. UCSF did recently change to a doctoral program for nurse midwives, and Cal State Fullerton offers a master's program for certified nurse midwives. So apart from those 2 programs, California does not have a local option for midwifery training. Next slide, please. All this being said, community birth in California is increasing based on birth certificate data, as well as which is incomplete, by the way, but as well as this California Healthcare Foundation report, which I believe cites the Licensed Midwife Annual Report. The number of births and clients served attended by licensed midwives is increasing, and planned out-of-hospital births are increasing, despite an ongoing, frankly, propaganda campaign against midwives. So the demand is there. The workforce needs improvement to meet this demand, and the training options are being limited. And the sites for community birth are being limited as well. Next slide, please. So here's another graphic of all California births by location. And so while we say community births are increasing, it's still a small amount of births taking place in the community setting. And this cannot be accounted for by risk status. It is not that fewer than 2% of people are appropriately suited for a community birth. There's something else there. It's that there's a shortage of providers, a shortage of it being geographically available, as well as this ongoing propaganda campaign that has normalized physician-led care in childbirth in favor of midwife-assisted care. Next slide. So community birth is increasing, particularly in communities of color who have continued to bear the brunt of maternal health, poor maternal health outcomes, healthcare that is informed heavily by racist policy, healthcare that is informed heavily by xenophobic policy. And we're seeing that home birth has increased quite a bit since 2000. And especially in the midst of the pandemic, people have ongoing fears about receiving care that will harm them while they are birthing their babies. And so the need for culturally relevant care in a community setting is there. The demand for it is there. And I just want to give a shout out to the midwives, particularly the midwives of color, who are just striving to meet this need and who are desperately understaffed and overworked as well. Next slide, please. So the statute for licensed midwives and nurse midwives is limited. It is limited far. It is more narrow than the breadth of their training and the breadth of their experience even prior to licensure. So nurse midwives have low risk written into their statute. Licensed midwives have normal pregnancy defined in their statute. The scope for both of these credentials of midwives is that it can include prenatal, birth, and postpartum care, care of the newborn, the management of most emergencies that come up in childbirth prior to connecting with hospital-based care or physician-based care. Nurse midwives, in addition, can provide gyne care across the lifespan, medical abortion and aspiration abortion. And also nurse midwives may collaborate with physicians to care for patients of moderate risk or with other chronic conditions. Next slide, please. So I do want to briefly talk about the history of midwifery in California, as this greatly informs policy. The material implications for the care of women in childbirth under this for-profit health system directly can relate to how midwives have been treated in California. So once again, the precursors to today's licensed midwives working in community settings have been attending births in private homes, maternity care clinics, and freestanding birth centers since California's founding in 1850. In 1917, AB 1375, Gephardt, was signed into law, which licensed and regulated midwives under the Board of Medical Examiners and established midwifery as an independent profession distinct from obstetrics and nursing. Pictured here is Bridget Mason, known as Biddy Mason, who was born enslaved, moved to California, won a landmark case that freed her, and then became one of the largest landowners in Los Angeles. But more importantly, she is a beloved historical midwife in California, and often miscredited as a nurse, but was a primary care provider for her community when they were birthing in like mid 19th century. So we can go to the next slide. And I discussed Gephardt. We can move on to the next one. So interestingly, midwives were licensed in 1917. World War II came along, and the majority of California's midwives, a large proportion of California's midwives, were moved to internment camps because they were Japanese-born midwives. And what we saw there was a movement of all of these midwives to internment camps where they were no longer permitted to practice midwifery. And then the legislature and the Board of Medical Examiners said, well, there's so few midwives in California, we shouldn't even be licensing them anymore. So 1949, this Midwifery Practice Act was repealed. Whether or not this was before or after a cultural shift toward hospital-based, physician-led maternity care, this transition was really accelerated by a campaign on the part of organized medicine and policymakers in the US and Canada to eliminate the practice of midwifery. And funding also came along with that. So in the 20s, or really in 1949, midwives were referred to as a dead class and a profession for which only 2 licenses had been issued in the previous year. They basically waited for the existing midwives in California to retire or die, and we all know that death comes before retirement for midwives who love their communities. And, you know, it was said that as a practical matter, midwives who engage in midwifery generally are nurses. So without acknowledging the role that this forced relocation and internment of all of these midwives had played in the steep decline of this profession's numbers, legal midwifery was eradicated and midwives were criminalized. So in 1974, California began licensing certified nurse midwives under SB 1332 to fill the clear reproductive health and maternity care gaps left behind with the repeal of the Midwifery Practice Act. During the intervening years, public demand for maternity care, particularly in a community setting, increased. And midwives were then criminalized. Particularly non-nurse midwives were criminalized during that time. By the early 1990s, California led the nation in the criminal prosecution of home birth midwives and became known for really aggressive tactics deployed by medical board investigators, which included sting operations, armed raids on these midwives and their offices and their families. So after a decades-long grassroots effort to reinstate legal status for midwives, the LMPA was passed in 1993. So 1993, both of these credentials of midwives are legal now. 2020 CNMs did gain legal authority to practice without physician supervision. 2013 LMs gained authority to practice without physician supervision. I would argue that both are continuing to be forced to practice with some form of physician oversight in order to survive in their practices. The best example of this now is the eradication of birth centers in California because they cannot be licensed by the state of California because of outdated policies that require physician supervision, time and distance requirement to be close to a physician, etc. Next slide, please. And I know we're running out of time. So California is still one of a handful of states where midwives are regulated by physicians in some way. States with this scheme, as Holly presented before, are known for their concerning maternal health outcomes and maternity provider shortages, a lack of experience or insight into midwifery care at all of the levels of regulation, from the legislative process through investigations and enforcement, gives way to a disproportionate criminalization of what is a normal gold standard of maternity care. The US also has a uniquely for-profit health system, uniquely for-profit payment models, and this gives rise to financial competition between and within provider types. In California, licensed midwives are regulated by their direct financial competition, and that can't be accounted for by any sort of coincidence or wanting to act in good faith, right? Worldwide, systems with the best maternal child health outcomes feature midwifery as the normal standard care and an independent profession that is regulated by a midwifery board or council. And licensed midwives, I will say, have been subject to an ongoing regulatory capture. We just celebrated our 10th birthday of being in a regulatory stalemate without active regulations to define and clarify what is and is not our scope of practice. And as a result, our regulatory body uses underground regulations in enforcement actions against midwives. Thankfully, and finally, the Medical Board of California has acknowledged that midwives need their own board, and they have recommended this repeatedly. I see that there are people from the medical board on this call, so I want to say, like, thank you. Thank you for coming. Thank you for continuing to support us. And I think that that is the end of my bit on this. Back to you, Holly.
Thank you. I think this is the part that folks are waiting for in terms of like, where do we go from here? And how do we create regulation and legislation that works to expand the profession and bring safe, quality care to people who need it the most? Thank you, Madeline, for that great background and what California looks like in terms of its midwifery landscape. Also, I did want to note that the Q&A is open if folks have questions they want to put in the chat right now. Hopefully we'll be able to get to a few of them. We have about 10 minutes left in this presentation, or scheduled 10 minutes left. And then there was a question, Madeline, about the white paper, what the topic of it is. And I think you said it's about the history of California midwives, right, and how that has shaped where we're at right now. Is that correct? Or
Yes, it is forthcoming from California Association of Licensed Midwives. It is not ready for prime time yet, but it is specifically in regard to the lost history of midwifery in California and why it matters today.
Gotcha. Thank you. All right, so where do we go from here? First, I want to note that we've actually made amazing progress with a lot of work around integration of midwives into the system. I am really thankful to Senator Dodd, who both in 2020 and 2023 put forth midwifery bills. The first one was nurse midwifery. The second had a combo of different licensed midwife and nurse midwifery components, and really laid the groundwork for kicking off the 2020 decade with some good integration of midwifery. Also, we see that HCI and DHCS and ACOG and others are really working with us to find solutions to the maternity access crisis and outcomes crisis. So you all can take a look at these bills here, but after 2020, after nurse midwives gained independent practice, Midwifery Access California was created. That's the website where you signed up for this webinar. SB 65, the Momnibus by Skinner, created the Midwifery Workforce Training Act. The Budget Act also combined the Midwifery Workforce Training Act in 2022 with Song Brown, which is the major funding for training programs that do primary care. SB 1375 allowed nurse midwives to perform aspiration abortion independently. After that, AB 1918 created the Repro Health Service Corps, which has directly funded abortion training by nurse midwives. SB 345 and AB 571 last year included midwives in the provider protections for abortion care. So we're really kind of on a roll here, and hopefully there will be more of this to fix this broken system that we have. Just a couple days ago, Assemblyperson Bonta released AB 855, which is a bill about birth center sustainability and the ability of birth centers to be licensed in California and to break down those barriers that are preventing licensed midwives and nurse midwives from licensing their birth centers. So that's super exciting. So what do you do as a person who might be looking to improve the maternity care system, and midwives are a part of that? There's some really important guideposts you need to know about. The International Confederation of Midwives is the global authority on midwifery. I'm going to go through a little bit more of that on the next slide, but there's also the National Association of Certified Professional Midwives, the American College of Nurse Midwives, Birthplace Lab, where there are some of the folks who did that midwifery integration study have a plethora of research and information and tools about midwifery and integration. Midwifery Access California, of course. The two associations on this call, CALM and CNMA, and the Nurse Midwives Foundation. So these are some basic go-to sources that you should keep in your back pocket. After this webinar, you will be receiving a toolkit of information, which will have QR codes and web addresses for these places, so you make sure you get to the right spot. So as I said, the International Confederation of Midwives is the global authority on midwifery, and what you can find there is this really great tool called their position statement on legislation to regulate midwifery practice. And a few things that stand out to me in orange here for what should be the foundation of California's next steps are: one, providing the mechanism for a regulatory body that is governed by midwives with the aim of protecting the public. Through legislation and policy, adopting definition and scope of practice that's congruent with the International Confederation of Midwives definition and appropriate to the country. Enable midwives to practice autonomously, because of course that's what brings midwives to places where they are needed most, instead of being, chained to health systems or hospitals or physicians. And set the standards of midwifery education based on global standards as well. They also have a regulation toolkit that reviews what not to do and what to do in terms of the regulatory environment. And I've given a couple examples there. And they have a regulation checklist where in the toolkit you're going to see this page filled out in terms of how California matches up to ICM standards for regulation. For freestanding birth centers, there are standards by the AABC. You can go there and get their position statements and the Commission for the Accreditation of Birth Centers. And finally, professional position statements are available at the National Association of Certified Professional Midwives and the American College of Nurse Midwives, which you can find at these QR codes. And so let's talk about midwifery integration through better legislation and regulation for midwives in California. So remember, midwifery integration equals better birth outcomes and increased access to care. Truly everything that is problematic with midwifery access in California comes down to how we've been regulated and legislated. So both the social and cultural acceptance of midwifery by consumers and physicians and other professionals is impacted by this. Payment and reimbursement equity, meaning sustainability of practice, is impacted by this. Institutional equity, or how we're viewed by the dominant model of care, the hospital model of care, is affected by this. Adequate and sustainable workforce, of course, is as well, and safety and quality of care. These are also the major pillars that need to be worked on in California still. So I'm going to give some examples here. First, regulation and legislation reflecting ICM standards. So one example is that the Medical Board of California, as was said previously, regulates licensed midwives. The solution is to transfer regulatory oversight for licensed midwives to an independent licensed midwife majority midwifery board with the authority to develop an evidence-based practice guideline that meets the needs of midwives and especially the safety of midwife clients. So this means greater safety for the public. This means greater chance of midwives being able to practice to the top of their education and training as suggested by ICM, which means increased access for consumers. What about payment and reimbursement equity? So here's an example. Current reimbursement schemes in California do not pay for the intensity of midwifery care, meaning the comprehensive care coordination, the one-on-one support, the always being on call, the ongoing risk assessment, social support connections, prenatal education, nutritional support. These are all the things community midwives do, by the way. Social support connections, one-on-one support during labor and newborn care. So of course, a solution may be looking into regulations and legislation that support alternative payment models for payers that reward the midwifery model of care, specifically as it pertains to Medi-Cal managed care plans who tend to pay the lowest to midwives. How can we incentivize that they actually pay for the value of the care that midwives give? Here's another example. Home birth is not covered by many commercial payers. Why not? Probably because of all the stuff I said previously and having old data out there that still is part of the cultural consciousness. This reduces access to maternity care during a maternity crisis. So a solution may be to mandate that all commercial payers cover the costs of home birth. Other states have done this. Here is what it looks like on the Aetna website. They say Aetna considers planned deliveries at home and associated services not medically appropriate. However, coverage of home births will be considered when mandated by law. So maybe there's an opportunity there for California. In terms of, I'm just going to check the time real fast. In terms of workforce, California only has one master's level CNM program and one currently paused doctoral program and no licensed midwife training programs. So there's lots of solutions here for the workforce. For example, directed funding for startup of CNM and LM training programs. We could also expand the ability for certified midwives to be licensed and have the legal authority to practice in California. That's the only licensure type that can't practice in California just yet. We could provide rules and incentives that enhance the number of midwifery clinical sites, because clinical sites really make a difference in terms of how many students can be accepted every year. We can create innovations in scholarships and loan repayments so that students will enter the midwife workforce to fill the access gap in high need areas. And we can think about innovations for building up a diverse workforce. Like if we directed funding to to a startup of nurse midwifery and licensed midwifery education programs, let's consider what not to do so that we can attract midwives from their communities who are more diverse. And then in terms of safety and quality of care, here's an example in California. We don't have easy or usable access to midwifery outcomes data. Data on licensed midwives is collected, but not really in a usable way, and data on nurse midwives is not collected, at least in the community setting. So there's a strategy here. A solution would be to change the licensed midwifery statute that requires them to submit their data to the Medical Board of California. This is data that's never seen or used, and revamp and fund a program that includes nurse midwives, because data can be used for research and quality improvement, and it's the one thing that creates increased partnership and trust across professions. Additionally, in California, the cost of malpractice insurance is out of reach for most midwives. So one thing that could be that other states have done are state-mandated joint underwriting association for affordable malpractice rates for midwives. And here is an example of this joint underwriting agreement in Washington state. The difference in California between $70,000 to $80,000 per year, which is unsustainable in terms of midwifery reimbursement, compared to about $12,000 a year in Washington state because of this legislation. So here's the final thing. One simple rule. When you are considering maternity care or reproductive health care in regulatory or legislative capacity, ask yourself, how does this affect midwifery care and access to midwifery care in California? Anytime something in reproductive health care comes up. And if you don't know, just reach out to us. Here's an example. In 2024, AB 2129 was a great bill. It mandated that insurers allow providers to bill for a birth and for immediate postpartum contraception, like an IUD, on the same day. This kind of same-day service was previously not reimbursed under most insurance rules. So how does this affect midwifery care? Well, per the writing in the statute, that this only applies for when a birth occurs at a licensed facility. Oops, I'm seeing that sorry, there's something weird on my slide here, but that's okay. So how does this affect midwifery care and access to midwifery care? Well, midwives who provide care in the community setting will not have parity with their institutional counterparts. They will either not be able to offer immediate postpartum contraception, such as an IUD to patients, which is bad for access and outcomes because they can't bill for it, or they'll have to eat the cost of that device, which is not sustainable, or the patient will be left with the bill. So a solution is, don't make the place of care the determining factor in what can be billed if it's within the practitioner's scope. So these are the simple questions that should and can be asked whenever maternity care is legislated. What happens with midwifery access and midwifery care? So with that, thank you for coming to today's presentation. This will be available to you online, a recorded version, as well as I said, some extra materials to guide your work. Please reach out to us at the Association of Licensed Midwives and the California Association of Nurse Midwives and Midwifery Access California. We're here to help. I know you all probably have to sign off, but we are going to stick around in case there are some questions. One person says, can you speak to if they're, oh, nope, went away. Let's see.
Yeah, there was a question about the community college licensed midwife program. That is all of the information that I can reveal at this time, that there is a community college licensed midwife program in the works that is being diligently worked upon for a very long time. So CALM members will get an update that will be reshared by Maka, undoubtedly.
Great. I'll see if anything comes up into the chat. All right, folks, thank you for joining us today. And oh, we have one popping in here. Are you all aware of the HCI funding for licensed midwives? Yes, we are. Thank you so much for that, Christina. You're right, that is part of the newer changes that HCI is doing administratively as well after the Midwifery Workforce Training Act. So really great that they are partnering with us on making education more tangible. So I'm a bit confused about the different types of midwives and thinking about regulations. Should all of them be treated equally? So licensed midwives and nurse midwives do have a little bit different scope of practice. As Madeline described, nurse midwives are trained for a hospital setting. Licensed midwives and CPMs are trained for a community setting. Because of that, certain parts about their scope of practice are going to be slightly different. But in terms of what's the same about them is that midwives should be regulating and deciding what that scope of practice is and deciding which cases should be reviewed, how discipline happens, etc. So they are slightly different, but the rules in terms of how to look at the regulatory and licensure process are the same. Hopefully that makes sense to folks. And Elizabeth, yes, of course you can. In a perfect world, if we did not have this mishmash of licensure types that, as I said, was born out of how this country developed its midwifery workforce, we probably would have a consistent one licensure type with different specialties. And then regulations would be able to kind of parse out what occurred in those different sites of care. But truly, we're a little bit far off from that, but we're hopeful that one day there will be a day where these professions have merged, where we've have a board that regulates all midwives, or hopefully a combined group of midwives. That's the goal. That's the dream. Anything else? So are there proposed legislation on the insurance front or other regulation issues, insurance for birth centers? As it is right now, I don't know of any that are actively looking to pursue something around insurance. I mean, there is talk out there a little bit because I think folks are catching on that reimbursement is key, that this is, we can't do this work if you can't get paid or get paid unfair amounts. But reimbursement and payment reform is absolutely the key to sustainability. Yeah.
I will also say that federal law provides that if an insurance policy covered under the ACA offers maternity care, it must offer that care by any provider licensed to provide that care. So there is a federal law that says that. California's implementation of that has been overall quite poor in regard to midwifery care, because California does not have active regulations that clarify midwifery care as being licensed maternity care in regard to the payer relationship. So I'm always available through CALM to have conversations about securing third-party reimbursement for midwifery care, but there is no active legislation in regard to that.
Yeah, and I'm wondering also if this person means malpractice insurance, liability insurance, as we discussed in one of the slides. And to that answer no. In fact, that's been kind of a tiny part of discussions in the past few years, so it's kind of not on the radar as we believe it should be. Yep. Right. I'll wait and see if anybody else pops into the chat. Oh, what are the first steps for improving legislation that you would like to see? Is this Holly personally or midwives as a whole?
Holly, personally, say it.
I think there's three big things actually. Regulatory, as I said, being able to have a midwifery board because that is crucial to patient safety. Boards are there for, to provide safety for the public. As it stands right now, if licensed midwives don't have regulations, that's not a normal way to practice, right? Secondly, if they are part of the Medical Board of California, they aren't privy because they're not on the board to things like disciplinary actions or what has occurred in certain cases that required disciplinary action. And that is incredibly important because that informs quality improvement and what needs to be done on the professional level to ensure safety. So and that's just a couple of examples, but that is top of mind. And from that trickles down other things like scope of practice, and from there trickles down access, and from there trickles down payment reform and so forth. So regulation is a regulatory board for midwives is a big one. Second thing that comes to mind is workforce is a problem. Given that maternity wards are closing, we only have a couple of programs in the state. So there have to be multiple levers that are pulled to ramp up workforce. So that could be many. There's not one bill that can do this, but here's an example. After World War II, the reason that residency programs existed and kind of proliferated quickly was that the United States decided to put significant energy into that and funding and connected it to Medicare. And in that way, it ensured that physician training programs existed and expanded. If midwifery programs and clinical sites for midwifery programs, if there isn't some big push from the state or federally, we're just going to be like clawing along here for years to come. So there needs to be a big push towards directed funding for midwifery education programs and the clinical part of that. There's other ways that workforce can be enhanced as well, as I said on that slide, but at this point, we need the space to be able to train midwives. And then finally, of course, I'm forgetting my train of thought. I said three things, but workforce and regulatory would be a really good place to start. Oh, payment reform. Sorry, that's it. Midwives are not reimbursed what they should be. Here's an example. Medi-Cal for a global fee for a provider the provider fee, and Madeline can correct me, is a little bit over $500. That's it. You can recoup a facility fee if you have a licensed birth center, which is somewhere in the $1,200 range. But as I said in a previous slide, only 4 birth centers in California are licensed because it's incredibly difficult to become licensed. So luckily, that's a bill that has been introduced. So if we don't think of ways that we can have Medi-Cal increase its rates for midwifery care, knowing that it results in better outcomes and overall lower costs to the state and to the health plan itself. That's a big deal. And at Midwifery Access California, we have put a lot of time and effort into designing a maternity payment model. That's an alternative payment model that addresses specifically what midwives need in order to keep their centers and their business growing and keep the lights on. You can find that on our Midwifery Access California website. So yeah, payment, workforce training programs, and regulation.